Hello, everyone. So today we are going to talk about nursing home care. Um, here are the objectives. In this lecture, we should be able to describe the demography and the characteristic of the nursing home population, risk factors for admission to a nursing home, the requirement of the Omnibus Budget Reconciliation Act of 1987. As well as the physician's responsibilities to nursing home residents. So here are the topics will be covered in this lecture, and we will talk each of them in details. So there are a lot of Americans living in nursing home now, and most of them are younger than 65 years old. Still, some of them are older than 65 years old living in the nursing home, and the number of minorities, including Hispanic, Asian, Black Americans, increased. And the number of older adults with intellectual and other disabilities living in nursing home also increased because their parent caregivers either pass out or are unable to take care of them because of the old age. And here are the reasons that those people living in the nursing home. And we can see that most likely they need assistance even with full ability on their daily activities. And today's population in the nursing home is more sicker with multiple medical conditions, and also the pressure ulcers is pretty common. Dementia is another concern, and the comorbid physical and mental diagnosis in this population are also common. And also a lot of more than half of the residents are treated with the psychoactive medications. And regarding the beds in the nursing home, about 70% belongs to the profit nursing home. Only 24% belongs to the non-profit nursing home. So that's why people from low-income families difficult to live in the nursing home. They probably need to wait for a longer time. And the service in the nursing home is really depends on the size and the locations. And some nursing home has a very fancy facilities, instrument, while some doesn't. So the function of a nursing home is response to the decline length of hospital stays and the higher care needs of older adults, and also it can integrate features of acute Medicare, long-term care, nurse, and rehabilitation. And also nursing home has the following functions, including dialysis, rehab, home care, and data central. 80% of people live in nursing home more than 90 days, and the short-term stay is mainly for the patient who need a short-term recovery and rehab. While the longer stay in the nursing home, the better outcome they have on their recovery. And regarding the funding of nursing home care, so most of the income are from the Medicaid, some resources from others like a donation or other resources. Well, still the minimum incomes from Medicare. In order to get covered Medicare, there are several requirements we need to meet, including prediction of a patient's function needs and the rehabilitation potential to help recover from acute illness or injury, and also need to document the gains in function during staying in nursing home, and also it requires 3-day qualified hospital stay. So I see this qualification is very restricted, and also for the first 20 days in a SNF facility, Medicare can cover all of the expenses. Well, for 21 to 100 days, require co-payment for the patient. Beyond the 100 days, Medicare will not cover it. And also, higher quality of care in the nursing home correlates with the total nursing hours ratio of RNs to other nursing staff. However, the turnover rates are very high because low income nursing home and heavy workload, and also stress and depression caused by treating those patients with the different psychological problems like depression, or the patient with dementia who are very difficult to communicate. So all of this can give the caregivers or nurse staff a lot of stress. And the high turnover rates associated with increased risk of hospitalization for nursing home residents as well. So in terms of physicians, the typical so basically they are mainly primary care internists or family medicine physicians, and devotes lower or equal to 2 hours per week to nursing home care. And the perception for them is that working in the nursing home need to do a lot of paperwork, and with limited reimbursement, and the environment, the long-term care environment is undesirable. So, but the reality is as a physician in the nursing home is very challenging. It requires excellent clinical skills and the sensitivity to a variety of ethical, legal, and interdisciplinary issues. So in order to improve the quality of a nursing home, so it's better to have a closed staff model to improve their service, and also that the quality of clinical outcome may be higher, and higher if the nursing home can limit the number of committed physicians. So in that case they can contribute more time to the nursing home in order to take care of the patient. And also the quality of prescription is also important in order to deliver a good treatment for the patient. So regarding the factors associated with nursing home placement, it includes increased age, low income, low social activity, limited family support, cognitive and functional impairment. All of these relate to the people who tend to live in the nursing home. In terms of interface of acute long-term care, so most nursing home residents are admitted from acute care hospital, and the residents have high rates of nursing home residents have high rates of hospitalization, most common due to infection, and the 5 conditions account for most hospitalization from nursing home: congestive heart failure, respiratory infection, UTI, sepsis, and the electrolyte imbalance. And this is very important. So whenever we see a patient has either of these 5 a problem, you really need to pay attention to it, and also let every of your coworkers or nurse staff to pay attention to them, try to control their symptoms very well, and in order to avoid send them to the hospital. The NP and the PA working in the concert with the primary care physician as a team in order to deliver a good treatment and the service for the patient. and also can have a better outcome. And the suboptimal information transfer is pretty common, including all of these problems like missing or ineligible transfer summaries, advanced directive not documented. So yeah, so we need to pay attention to it. So whenever you want to transfer a patient from hospital to the nursing home, be careful of this problem, or with it's better to make a list and mark each of them when we mark each of them if any one of them is completed. In terms of the intervention to reduce acute care transfers, people can. The goal is to reduce frequency of hospital transfers. They can develop with the support of CMS to improve early identification, assessment, documentation, the communication of the status changing in nursing home residents. So the Omnibus Budget Reconciliation Act, aka OBRO, passed in 1987 to set training guidelines and minimum staff requirements for nursing homes. It mandates that each individual in nursing facility receive and be provided necessary care and service to achieve and maintain the highest practicable physical, medical, and psychological well-being that can be obtained, and also to maintain residents' rights, including limiting their use of restrained psychoactive medications, and also initiate the minimum data set in order to evaluate the service of the and the quality of the nursing home. It also requires documentation of need for all medication, particularly psychoactive agents. So the minimum data set, aka MDS, it's an accessible tool to measure the quality of a nursing home. It requires periodic comprehensive clinical assessment of all patients, all the residents. And also it's used to compare nursing facility quality measures, and also identify a current or potential problem trigger review of diagnostic and therapeutic protocols. And MADS 3.0 includes 5-star quality ratings for nursing homes, includes part of publicly reported quality measures, and also developed to help consumers, families, and other caregivers make a comparison about nursing homes in order to make a decision that which one is good for their family members to go. And also it's based on 3 sources of data at least below, listed here. So the MDS also evaluates the quality for the nursing home based on the percentage of facilities residents who are prescribed antipsychotic drugs, and also based on the hospital readmission and the prevention for avoidable declines in resident function, and also based on the moderate to severe pain was removed. So all of these matters. So the allegation, regarding the legislation of the nursing home, each federal regulate for long-term care is given a tag number, which is called TFTF tag, and the regulation is assessed by mental side visit service every 9 to 15 months, and where facility procedure, quality of care, and quality of life for residents are reviewed. A failure to meet regular standards for care is called a deficiency. Penalties are imposed related to the nature and severity of deficiency. So there are a lot. So there are some penalties that will be happened. So as described here, if there's a deficiency, so so the nursing home will be the number of patients in the nursing home will be limited, so it will be decreased. And also, if the problems continue still there, so the nursing home probably will be shut down. So the role of medical directors include coordinating medical care, setting qualities, ensure compliance, working with the administrator and director of nursing to foster effective care and appropriate continued staff education. So actually in the world, only Americans have the medical director in the nursing home. Take responsibilities of all these items. The overall requires mostly evaluation of medication by a pharmacist, and medication must be reviewed at regular interval and include no unnecessary drugs. And here are the list of the example of unnecessary drugs classifications. So basically, overall, it monitors, supervise the nursing home to make sure that the patient medication appropriate. The overall requires that the clinical documentation demonstrate indication for all medications, especially for the psychoactive drugs, and also the dose of the dose of psychoactive drugs also required to document it, and also are mandated to gradually reduction unless a clinical contraindication exists. So the challenges in the nursing home medical care, including the heterogeneity of residents, necessitating individualized approaches to care, typical and subdocumentation of units, limited access to biotechnologies. So all of these are the challenges of a nursing home, and also including the collaborating with families in care plans, ethical and legal issues, intense regulatory oversight. So we can see that there are a lot of challenges there, but still, I mean, we need to work on those challenges. Here, so in order to solve those challenges, here are some new model of a nursing home created. So first one is Eden alternative, which focus on the development of a relationship, collaborative partnership between caregivers and older adults, and also develop a human habit with continued contact with plants, animals, and children, that the older adults to live in a very happy environment. A greenhouse model creates a small groups, 6 to 10 people in a group, live in small non-institutional homes with a residential neighborhoods, and provided by empowered direct care staff that accomplish all care and meal preparation. So in these new models, a patient can have a very good relationship between their good relationship with their caregivers and other patients. And the evidence to date suggests this model improve resident quality of life, and it also good for the employee satisfaction, and preserve improving quality of care. But additional research is needed for the benefits and the costs. So in terms of enhancing physician practice in the nursing home, so here are some recommendations: schedule and structure visits to improve the and improve efficiency and become better integrated into the healthcare team, and coordinate with the NP and PAs, document the rationale for each medication and intervention to protect against potential scrutiny. The hold frequent discussions with the faculties, consult pharmacists. And physician practice regarding the physician practice in the nursing home, physicians' responsibilities include comprehensive admission assessment, development of a care plan, periodic monitor chronic health problem, promote and prompt and thorough assessment of acute medical problems of changing function, communication with the interdisciplinary team members, resident and the family, and periodic review of all medications, optimization of quality of life and function, determination of each resident's decision-making capacity, as well as physical attendance to each resident. So about in terms of advanced care planning, so we should understand each nursing home resident's preference for care, and it's very important. But this can also be challenged because nursing home setting, in the nursing home setting, number of residents who don't have medical decision making capacity has been noted to be as high as 44%. And the early advanced care planning may be invaluable for nursing home residents and those at risk of nursing home placement. Racial inequity is another issue here. So the white residents are more likely than black residents to have a living will and DNR orders. Telemedicine is a really good way to communicate with the patient and the health caregivers and the team. CMS recognized telemedicine as a viable service and provides building mechanisms. The evidence has increased that telemedicine can reduce hospital admissions and improve overall quality of care in the nursing home setting. So here's a summary of this lecture. So we talk about there are a lot of Americans living in the nursing home, and nursing home evolved dramatically in the recent years. And we also talk about the federal law requires periodic assess of the all residents in the nursing home. The medical care of nursing home residents challenge, and we also talk about some new models in order to overcome those challenges. So here's a question. Yeah, please read it and answer the questions. 92-year-old woman who lived in the nursing home falls on her way to the bathroom. 1 hour later, staff knows that she's mother confused. And she's a febrile, but her urine is darker than usual. History includes dementia, UI, bilateral knee osteoarthritis. In the last 4 months, has been treated on UTI 3 times. Staff nurse calls patient primary care physician to request a UA, and the facility antibiotic stewardship team reviews the patient's case. So what's some effective strategy that the team can implement? Each one, protocol for promoting initiative for antibiotics, routine urine test in high-risk patients, post-treatment urine culture to ensure cure is achieved, or periodic in-service education for staff on symptomatic bacteria. Yes, DES. So I think it's a very common. It's a common sense for doctors and the medical students. So asymptomatic bacteriuria, especially for the older adults, we don't need to treat it. So just periodically in service. So based on the patient conditions, She has no symptoms because of UTI, so we really don't need to treat it. And all other protocols actually are unnecessary. And here's the second question. 78 years old male is transferred to SNF for post-acute care after hospitalization for pneumonia with sepsis and heart failure. He has delirium and physical disconditioning during hospitalization. Before this illness, lived at home with wife and ambulate independently. And now he needs moderate assistance with ADLs. History includes diet control diabetes, systolic heart failure, CAD, hypertension, mild dementia, stiff CKD, current medication including lisinopril, metoprolol, aspirin, donepezil, which following increases risk of hospital admission, dementia, baseline function status, medications, or comorbidities. Yeah, comorbidities. Remember, we mentioned that the 5 most common reasons for the patient readmit to the hospital from nursing home, including heart failure, UTI, respiratory infections, and other infections, and sepsis. So let's go back to this slide. You can see that the patient has a history of heart failure, which is one of the which is one of the 5 risk factors that make patients more likely to go back to the hospital. And dementia is a lower level of risk factors. Baseline function status should be fine, and he actually has his function status actually is good. Medications, only 4 medications here. We don't need to worry about the polypharmacy issues, so D is the best answer. Okay, here's all here's all of the information of this topic, and I hope you have a good one. Thank you for watching.